So, as I said, I'm a surgeon, but what I'm talking about today is definitely of interest to everyone because, you see, I think the topic of patient safety is not new. It is something which concerns all of us and has concerned all of us from times immemorial. So it's as old as medicine itself. And as all of us are aware, this first do no harm. All of our patients trust, they expect, and I think they very much deserve that doctors will take them through their journey to the hospital safely. So, most of us, and many a times I ask this question, like, why did you come to medicine? And so, a lot of answers are there. And I feel most of the people who come to this profession come to help. And so, if they had their way, nothing would ever happen to the patients because who will be happier than the doctor, or the healthcare worker when patients go home well? But I was also extremely surprised when I came to know about this. This is from uh, the Institute of Medicine 1999 that as many as 98,000 people die. And this is from the US every year of preventable medical errors. So, 98,000 may not mean anything, but if I tell you that this is equivalent to a jumbo jet full of patients dying every day, then you can probably understand the magnitude. And these deaths, they exceed the number of deaths due to motor vehicles or breast cancer or even AIDS. So, and this was not an isolated thing. There were studies from other countries which showed that like adverse events happening in during patient care is quite a common event. And this study, which reviewed the medical charts of 30,000 patients from the hospitals in New York, they found that an adverse event was responsible in prolonging the time spent in hospital or producing disability at the time of discharge in as many as 3.7% of patients. And as many as 58% of them were considered to be actually preventable. Similarly, there were other studies. So now we know that from these older studies, which said that an adverse event occurred in as much as 16.6% of admissions, resulted in permanent disability in as many as 14% of patients, and death in 5% of them. And more than half of them were considered preventable. So if we see globally, then at least 1 in 10 patients is affected by adverse events. And some parts of the world, these may be actually as much as 2 to 18%. And if you see, these are quite staggering figures that 14% of them are responsible for leading to permanent disability. And if we see deaths in hospitals, 30% of deaths, the causes can be associated with an adverse event. So, what I'm trying to say is that if we consider that there are about 421 million hospitalizations around the world, there are about 42.7 million adverse events. And two-thirds of all these adverse events happen in the low and middle income countries. As we can see, about one-third of them are associated with surgical procedures, but as many as 18% are associated with medication errors, and quite a bit of percentage is related to adverse events resulting from the healthcare associated infections. So there is quite a bit of mismatch between what we perceive should be and what the reality is. Like we all think that healthcare, should be safe, and but if we see the figures, then it is obviously not. Now, if we look at what kind of adverse events are common, then there's a whole list. There may be improper transfusions, there may be surgical injuries, and although in reports and all, it is usually the retained foreign bodies or wrong side surgery which catch the imagination of the media, but things like improper transfusions or restraint related injuries or falls, burns, and mistaken patient identities, hospital acquired infections, they form a large percentage of what we consider as adverse reactions. And I think it would be intuitive to understand that higher rates of adverse events with more serious consequences are more likely to occur in intensive care units, operating rooms, and emergency departments. Now, here, I mean, if I ask all of you who are attending, why would you think that such uh, events are more likely to happen in these settings of ICU, ORs, or emergency departments? Would somebody care to answer? Anyone? I mean, intuitively, what comes to your mind? No one? Why I wanted someone from the audience to say, hello? Okay. Uh, I think I will come back to it once I start talking about. Hello? Yes? Is someone trying to say something? Hello? Okay, let me continue. So if we talk about the price that is paid for adverse events, I think it is easy to understand that they increase morbidity, at times mortality, permanent disability, hospital stay, and therefore the overall cost of the treatment. The thing is that it is not only just financial loss which is experienced by the patient, the patient's family, the hospital, the healthcare services, but also some other price which is more difficult to calculate in terms of human lives, the physical and psychological discomfort, the loss of trust in healthcare system, the diminished satisfaction with the healthcare system, and also the loss of morale on the part of the healthcare workers and the frustration. And because of the disability or the increased hospital stay, the loss of worker productivity, reduced school attendance, and lower level of patient health status overall. So, if we consider only in financial terms, then for the low middle income countries, the cost of all adverse events averages about $7,295 million. So you can imagine that how I do not know the figures for India, but if a country like the US is ending up spending so much for adverse events, we can imagine what it would be like for a country like India. If it is difficult for these developed nations to afford adverse events, how much less can countries like us afford this? So, this whole topic or the whole issue of patient safety fundamentally is geared towards trying to prevent the inadvertent harm caused by healthcare errors and system failures. I use the word, I think the term inadvertent because hardly I think the percentage of psychopathic doctors would be really minimal to have us worry about them. It is all of us who are not psychopathic, who would not intentionally harm patients, but end up harming patients. So I think it is important to understand that when we look at patient safety, we are trying to see why inadvertent harm still happens in the hand of people who do not want to cause harm. So the patient safety, once we start looking at, why adverse events happen, then we can learn how to minimize the incidents, and if not the incidents, the impact of these adverse events, and how to maximize recovery from them. Because just because an adverse event has occurred, it does not mean that it should have the ultimate effect of, say, a mortality or a serious morbidity or disability. So now coming down to why do adverse events happen at all? Again, I mean, I would be really happy for someone from the from among these students to say, why do you think adverse events happen? No? Hello? Hello? Can I, am I audible?
Anu, I think they
Yes, ma'am.
probably cannot unmute themselves.
Yes, ma'am.
Oh, okay. So I
No,
cannot interact with the people at
no,
all.
I think one person, Abhinav, wants to say something. Yes,
Ha,
Abhinav.
please, Abhinav. Ha.
Yes, sir, audible, yes.
Okay. No, so I just wanted some. So, sir, who can unmute them? Like, if somebody raises a hand, can we interact with them at all?
Yes, ma'am.
Abhinav is unmuted. Abhinav, you want to say something?
Ma'am, we can. Ma'am, actually, people are unmuted.
Okay. I
Anu, you
think there
please
is a.
carry on because they have.
Okay, I think so. Okay, so let's forget about it. So, see, if we see the if we see today's world and the technological advancements, I think the one example is right here. We, instead of meeting in person, we are on Zoom. So it's great in many ways. Like, all, I am sitting at home, someone is sitting somewhere else. We are all able to talk. But see how, because this is the first time we are doing it like this, still glitches are appearing. So yes, technological advancement makes things easier, but it also makes things more complex. And therefore, there is a need for expertise, there is more to learn, there is rapid change, and we need to keep up. Every time there is a new, like in my surgical, this thing, if you have a new machine, then definitely I and my entire team, we need to learn. So it is not that technological advancement, it's its own double-edged sword. Similarly, these days, like, Google Uncle at our click, so it's like a deluge of information. We are almost drowning in information. So more knowledge sometimes does not translate into more wisdom. There is more confusion also, and there is need to know more, and there is processing and assimilation of more and more. So is more always good? So see, because we have so much of technology, we know so much more, but what we are doing is that we are doing more and more complex interventions on older and sicker patients in a multidisciplinary approach. So this adds layers of complexity, and I will come to how this can contribute to the occurrence of adverse events. So you see, these days, when from, if you remember, say your grandmother or grandfather talking about the family doctor, there would be one doctor who would know all the family members. He will also know, all the histories of everybody, and it was a simple kind of affair. But now a single patient coming to the hospital will have, the whole process would be so complex, and he or she would be coming in contact with so many people, and something could go wrong at every point of interaction of the patient with the healthcare system. So this makes the entire process at a risk of error at every step. See, I think sometimes, when you've come to SGPGI for the first time and you go to the ICU, at least I can remember this, you get lost. Where is the patient? Like, so much of, there are infusion pumps and there are monitors and there is everything, and the patient is lost there. Believe me, all this is very good, but it adds its share towards the likelihood of errors also. So, one thing is very clear, that healthcare delivery today has become more and more complex. There is more to know, there is more to do, there is more to manage, and there are more people involved than ever before. The change that has happened in recent years, when people have started thinking about why errors happen, one fundamental thing that we have learned is that, what is our usual uh, response? Some, I think all of us must have experienced this, that supposing a patient has an adverse event, or you come to know that a patient has been given an wrong dose or wrong drug, our first this thing is kisne kiya, who was it? So the this individual error of, name the patient, name the person, blame, shame, and punish. The thing about this is that it is ineffective
जबरदस्ती मत करो, बस आराम
in
से जा,
prevent
जबरदस्ती कैलिब्रेशन करने की जरूरत नहीं, ठीक?
This approach is fundamentally ineffective in preventing future errors. You may have named, blamed, shamed, or even punished that person in whose hands the error occurred. But does someone else can commit the same error if the fundamental cause has not been seen? In more recent years, the thing is, what we have started doing is that we want to identify systems or processes and conditions. We want to understand why people make mistakes or why people fail to prevent them, so that we can improve the basic structure and make it difficult for individuals to make mistakes. So basically a system, if I say a system, it's a set of interdependent elements which interact to achieve a common aim. For example, if I talk of the OT or the operating theater, since I'm a surgeon, so the OR is a one big system where there is technology, where there are human beings, and there is equipment, and everything is interacting with each other, and it's a complex system. And we will be able to understand errors if we understand how this system works, not just the people in it. So the person approach or the individual approach focuses on the unsafe act, whereas the system approach sees that errors are a consequence of unsafe systems, and they try to build defenses and safeguards so that people are accountable, but not just for the sake of blaming. I will explain this further. Say, for example, in the individual approach, if I say, what does the outcome of surgery depend upon? And you would say, okay, yes, there are definite patient risk factors. Say a patient has multiple comorbidities, we understand, but the surgical skill, is considered to be one most important factor in the outcome. But the system approach understands that no, apart from the patient risk factors, apart from the skill of the surgeon, there are other things like ergonomic factors, organizational culture, the quality of decision making, team coordination, and leadership. Now, how? Let me give you a few examples. Like, for example, wrong site surgery. I think all of us may have been a part of this at some point or the other. Now, if I say that, those of you who have been in the ORs, many a times the consultant may enter the OR once the patient has been painted, draped, anesthetized, and then the person comes. Now, if the junior most member who happens to be in the OR earliest, or the anesthetist, they do not identify the patient by name, CR number, or whatever, and the consultant comes late, consultant may not even know which patient he or she is operating upon. So there is a likelihood of error, no? So if the team coordination, for example, the junior most person has identified that say for example, the right limb was to be operated, but the marked side is left, and he doesn't have the courage to tell the consultant, I think the chances of error are more. So what I'm trying to say is that more things than just the individual people is actually responsible for the errors that happen in healthcare. For example, the entire profile of the operation, the surgical team, procedures, operative events, everything is important. The operative environment. See, many a times you must have seen if there is too much noise in the environment, you find it difficult to concentrate, right? So whether you are at home or you are at work or you are in the OR or trying to do a procedure, your environment affects your performance. So the system approach to patient safety looks at all these things and tries to make an environment which reduces the chances of error happening. See, once people started looking at what was the root cause of wrong site surgery, they understood that it was not the patient assessment or staffing or competence or credentialing of the operating surgeon, but it was errors in communication which was actually responsible for the root cause of wrong site surgery. I remember once we had a whole surgical gastroenterology week, a CME, on safe surgery. And I remember Dr. Kapoor had talked about one Shanti Devi who was posted for a urological procedure being shifted to gastrosurgery because another Shanti Devi was actually posted for a cholecystectomy. So, these errors of communication, person has gone out to wheel the patient in. Shanti Devi has only checked Shanti Devi. So both the Shanti Devis have gone to the wrong theater. So these things happen. So the system's approach to patient safety looks into these. Similarly, human factors. See, I think doctors of all the people, actually most surprisingly, do not consider themselves liable to make mistakes, which to me is very surprising actually. because most doctors are intelligent. They have always done very well in their studies. They are usually among the top 5 or 10 of their class. They have come to a specialty or a system which they want to. It seems very difficult for them to understand that even with all this, mistakes happen. So it is important for them also to understand these human factors. What are human factors? It is basically study of all the factors that make it easier to do work in the right way. And this applies wherever humans work. So it definitely applies to healthcare. This is also sometimes known as ergonomics, because ergonomics means study of people's efficiency in their environment. Now, here I would have definitely wanted some feedback if it is possible. Do these lines appear crooked or straight to you? Only one person can answer. Or, sir, you can answer, Dr. Kapoor, if you are able to hear me.
The
Yeah.
baby said,
Are they crooked or straight?
yeah, one.
Are the lines crooked or straight?
Right.
They are crooked.
So I'm just trying to say, I should say, do they look crooked or straight? Because our mind tries to be smart. Similarly, if we look at the chart and say the color of the word, not the word, for example, the top, you should say green. Then the next one, you should say red. And then you say blue. Try to say it in your mind. Is it hard? I think it is hard because our first thing is to read the word yellow, blue, orange. But if I say just read the color of the word, it is a little difficult. Similarly, what do you see? Again, I think anyone who can hear me can say, what do they see?
Back of a head, or maybe two girls.
Is it a young girl?
Probably can't say. The face ahead, the nose, which you can see, looks like a young girl, but the eye looks like an old lady.
So some people will see an old lady, some people will see a young, and if you see the old lady, you can't see the young. If you see the young lady, you can't see the old. Why am I showing all this? Here, Preeti, you can see yours. You can tell me, what do you see?
Two people facing each
Two.
other.
If I say I see a white vase,
Yes, true. True,
if
actually.
you see the white, what I'm trying to say is perception, human perception is fallible, right? And somehow, if you look at these, you know, don't you think it would be very easy to just mistake one for the other? And this happens all the time.
Easily.
Two very different drugs, identical boxes, identical bottles.
Sorry to interrupt, Anu, but there is a real life example when Digene was prescribed 2 tablets every 6 hours and digoxin was given.
Oh.
Yes, sir, this is actually, this confusion is everywhere. So, these days, I think Preeti only told me she carries a magnifying glass
Yeah, I
because
do.
what is written on the back of most of the strips that we get, we can't make out. The other day, I went to buy levofloxacin. The chemist said it costs only 5 rupees. I was very surprised. I said, which company is this? So he said, he gave me some example, but then he said, ma'am, Levocet. I said, Levocet? So he had given me levocetrazine. I had asked for levofloxacin, but I am a doctor. And I wouldn't have thought, but because it was only 5 rupees, I asked. Had it been some other patient who required levofloxacin, would have taken the levocetrazine and gone home. So actually, so this, what I'm trying to say is, the way the system is, the way the environment is, error is actually very likely. So human perception, as I said, is fallible. And therefore, since our decisions depend upon our perceptions, our decisions and actions can also be flawed. So mistakes can happen regardless of experience, intelligence, motivation, or vigilance. So we cannot rely only on them. Errors are inevitable even for doctors. And why it is important to actually really internalize this is, as Indians, we are very difficult to put into systems. Like if we go to Singapore, we will not spit on the road. because there is this thing. But if we are in India, someone else tries to tell us that if you do thing like this, whether it is following traffic lights or whatever, we are remarkably recalcitrant to this kind of advice. But if we understand and if you see the impact of errors which happen in healthcare system, I think it'll be a big learning experience. So going on with this human factor, when are the chances of error, high? If we are unfamiliar with the task, I think as doctors you would know, when you were a first year resident vis-a-vis when you are a third year resident, or when you go to a new place or you are given something new to do, if you are unfamiliar, chances of error are high. Therefore the importance of supervision, inexperience, and if somebody is hurrying you, like if it's a shortage of time or inadequate checking. Similarly, poor procedures and this poor human equipment interface. I remember first time I used the uh, harmonic scalpel, and they said there is a hand switch also, there is a foot switch also. I ended up using always the foot switch because somehow the distance between the thumb and that switch was not optimum for comfort. So all these things actually lead to a increased risk of error. Similarly, see, now here is what I want all residents to pay attention to. As doctors, we never think fatigued. Anybody, no resident, I do not know if things have changed, but at least no surgical resident would ever admit to being fatigued, hungry, sick, or say that I didn't understand this, because all of this is associated with or ascribed to people who are weak or whatever. I do not know. But we are humans and our performance is affected by all these things. Now, this I always like to say, 24 hours of lack of sleep, the effect on you is exactly the same as your blood alcohol content being what will make you legally drunk. So therefore, you are not fit to drive. So if you are not fit to drive, you are definitely not fit to take care of patients. And I have myself done this 3 nights in a row on night duty. Fourth day, I slept on the operating table because we are not taught that it's nothing very brave or very chivalrous about not sleeping and still working. You are not doing anyone any good. There is, now we know that very low levels of stress can lead to boredom and reduce efficiency, but very high stress can lead to anxiety or panic. And there is an area of optimum stress, and there you are being fed, you're not being hypoglycemic, you're not being sleep deprived, betters your performance. So human factors basically acknowledge the universal nature of human fallibility and the inevitability of error. See, just as because we know that gravity is inevitable, we make parachutes, no? We don't jump. So similarly, once we know that these things are there, errors will happen unless we design things in such a way that the likelihood of error or the consequences of errors are minimized. So, now, because once we know that human beings are human and they will err, the thing is that we try to make our systems like in such a way. See, why did Europe and all those places, they reduce the hours of residency times, like how much time, 8-hour shifts only. And I, in fact, happened to speak with many people because as surgeons, it was kind of unheard of. We could never think surgical residents, or even I keep on saying surgery, please don't take it otherwise. It's simply because I'm a surgeon. It was thought that surgical residents are on call 24 hours a day. And if anybody, felt otherwise, then he or she is not fit to be in surgery. They said that actually the efficiency really increased once this was taken care of and the work hours were reduced. Similarly, say team coordination. See, nobody would put it in your medical curriculum, but all of us would have understood intuitively. There are some people we want to be in a team, like we, pata chale kiske saath meri night duty hai, whether it is in the nursing staff or why is it? Because you know that in teamwork is most important in the healthcare system. Working environment, for example, this I always feel, and I supposing how likely are you to tell the truth to a senior who will rip your head off if he or she hears something which he or she doesn't like. I mean, we can pretend whatever, but I feel like, hierarchy is important, but not in such a way that the junior can never utter anything which is of importance as far as the patient management is concerned. So human factors, they, take into care, engineering people take into care all these things so that they make it in such a way that human beings find it easier to work, whether it is with devices or equipment or whatever. So basically to try to reduce error or at least its consequences. Similarly, say for example, because it is in howsoever intelligent you are, you cannot remember all medications and all drug interactions. So supposing we make it electronic, we make it in such a way that the computer, the program will not allow you to order a drug which has a very serious drug interaction with one that the patient is getting already. Don't you think it would be safer? So if somehow these, see, where I have seen in front of my own eyes 10 times the dose of fentanyl being given. See, you may not see that point, you may not see that decimal, you may not see that 1 0, and it can lead to a 10 times the dose being given. So if we can take care of this by things like electronic ordering, it can definitely make things easier. See, a very simple thing. You must have seen patients being shifted from the trolley. Now, it is not only difficult or injury can occur to the patient. Believe me, lot of back injuries to the nursing staff and the attendants happens when they shift a patient from the stretcher to the table. A very simple device. It's just like a board on which you can slide the patient and it can ease. So this is seeing human factors and trying to make things easy so that injuries to the patient and the healthcare workers don't happen. So we think of these things only when we look at things in this way, right? Also, the human factor approaches know that before a serious adverse event or complication happens, before that, a chain of individually unimportant errors have happened and they contribute. Now, I always say, for example, sometimes if, say, many of you must be married, both of you are working, you have a small child at home, early morning, your daily household help calls to say she or he will not come. Now, one person has to go to the OR, the other person has to go to the OK, and suddenly your mindset is totally, once you make arrangements, then one of you reaches late. Do you think, at least I feel all of this has an impact on in what state of mind you're going to reach the hospital. And many a times I ask people, does having a crash have anything to do with patient safety? I feel it has. If every morning you can leave your child safely in a safe place, I think you will come to the hospital in a safer mindset. Because performance is affected by all those things. Supposing 3 people get sick in the morning so that the OR is understaffed. All those things, you come in the morning, the power breakdown is there, half of the phase is gone. All of these things are going to affect. So what people have now understood is that before you reach the patient, if the system, by means of, say, written instructions, standardizing, having SOPs, having automation wherever it is possible, and improving devices and architecture, by the time we reach the patient, there are layers of safety in between which can help in reducing the likelihood of error. And believe me, this also I always ask, if as an audience I ask you, what if you had a choice between flying somewhere and having a surgery, what would you choose? I mean, I think everybody would just say flying, because despite the fact that so many tons of steel up in the air, it's still, by now you think it is safe. But surgery, as soon as the word surgery is mentioned, fear comes in your heart, right? Because we know that it is not 100% safe. See, these, normally we think that surgery is high risk, but believe me, working in a nuclear reactor area, flying an aeroplane where so many lives depend on you, that is also an equally high risk area. And those people have really learned from the mistakes which happened. I always give the story that I think it was in the 70s that uh, aeroplane, Pan American Airlines, and I think KLM. The KLM plane rammed into a stationary Pan American Air, and all people aboard died. And when they looked into what happened, because they have the black box from which they can make out, it was not. The pilot was one of the most senior, had I do not know how many hours of flying behind him. But when they asked the air traffic, do we have clearance for flying? The co pilot, who was much younger, said he didn't hear a yes. But he didn't have the courage because he was so junior, he didn't say emphatically. When the senior said, no, I heard yes. There was no yes, and they rammed into a stationary plane. So, see, they have understood that the sources of errors lie much more in leadership, communication, teamwork, and decision making. And industry actually welcomed this research. And the lessons are that they have invested so much in these error management tools. They have checklists, they have briefings, they have standard operating procedures, and therefore they are able to actually provide consistent high quality care in high risk environments, something which we need to learn from them. See, and now if you see, then the airline fatality rate has really gone down by 87%. And you must have seen, many a times when you're sitting in the plane, people are going around with those flipboards, ticking, ticking, ticking. This is pre-flight inspection. They will not let the ground staff will not let the plane fly till everything is tick, tick, tick. Because if anything goes wrong, howsoever experienced the pilot, whatever be his intentions, something will happen, right? We have tried to do that healthcare very recently with the patient safety checklist, which is similar to this. And now even skeptics, they know, because this has been tested in clinical settings, that, and India was also a part of this. There was this clinical validation of the WHO checklist. And I think you people may be familiar that before the procedure, before the skin incision, and before the patient leaves the OR, there are certain things that we have to leave, ask, and confirm that they have been done. You know, that for example, that the count is complete. And before the patient is anesthetized, we look at the identity of the patient, the site of the surgery, any medication risks, any allergies, the airways, whatever. So a host of things, and people have modified it according to their needs. And the checklist has been validated by WHO, and it was found. Actually, this data was collected on, about 4,000 patients, and as I said, India was also a part of it, and this was published in the New England Journal of Medicine, and they found that it definitely led to a reduction in mortality and in patient complications. So the lesson is that healthcare is complex. When things go wrong, then a systems approach is more productive for patient safety than a person approach. And as such, when Dr. Preeti said that patient safety is like a 0-1 course, you can go on and on different aspects. I just wanted to introduce the systems approach and the human factors so that you can become aware. So how does it kind of translate? How do we translate this in our daily practice? So I will give you an example. It's a true thing actually, that a nurse connects a bag of formula for gastrostomy fee to parenteral nutrition line, and the patient develops severe respiratory distress, hypoxia, brain damage, and survives. Now, the individual approach would be, as I said, bulao kisne kiya, fire her, do whatever, and reprimand it. And as I said, the thing is, another day, some other nursing staff will come and do the same thing. But if I use the systems approach, I'll say, why did it happen? What was wrong? I mean, why did it happen? So if I see, I'll tell you, the other day, one of my junior colleagues rang up to tell me that one mismatched blood transfusion had happened. And he was agitated. He was very disturbed that one of the most experienced staff nurses was there and this happened. I just asked him, I said, was it at the time of duty change? They said it happened at 2 o'clock, like that. And what I'm just trying to say is, if we see, and then how do we modify? Say, for example, if the jejunostomy or gastrostomy feeds, which are meant to not go in IV, have the kind of fittings so that they never fit an IV line, then no, howsoever ill-trained the staff may be, this complication can never happen again. So a simple change so that a gastrostomy bag cannot fit into an IV line can take care of it. So that is how the system approach is different from the individual, right? So now patient safety basically is all about minimizing incidence and impact of adverse events and maximizing recovery and learning from mistakes and not hiding. But this will not happen if our approach is to blame and shame and punish, right? So basically, obviously, no single person can do this. Patients, the healthcare team, and even organization and national policies. Say, for example, if the leadership in your hospital is not ready to take on patient safety as one important priority, no one can do it. See, I will tell you, a few years ago, it was we didn't have these hand rubs at all stations. So much so that I had gone to see a consultation in gastromedicine, one floor below mine. I asked the sister for hand rub. This is several years ago, and there was no hand rub. And she said, "Ma'am, हमारा surgery ward है, थोड़ी ना है." As if it's only so I said, don't your patients have IV lines? Don't your patients have catheters? But what I'm trying to say is, unless we make patient safety a priority at all levels, it cannot. And even national policy. See, nowadays, all many private hospitals are far more attuned to this because they have to get accreditation. So national policies and organizations also, you will not get NABH accreditation if your patient safety profile is not up to date. So, and one thing which always surprises me is that although at the center of it is the patient, we do not involve the patient. Now, if the patient can also be made a partner, for example, would you ever think that any patient would have in our setting the way it is, can say, doctor, please wash your hands before examining me? I don't think so. Or that I am taking, if the patient can say, I'm allergic to penicillins or whatever, please check the other medications that I am taking. And please, I cannot understand your handwriting. Can you please give me a printed list? So patients can also be powerful, components of our patient safety. So we can have written instructions for them, like say before surgery, after surgery, or what their whole, once they are in the hospital, what all is going to happen to them, so that they can ask questions and they can be educated about it. Similarly, it will always remain important that we have the knowledge of the subject and we have the skills. But I think as a profession, we have to kind of work harder in terms of, how good teams work, importance of leadership, importance of stress management and work hours. I still keep on hearing, like people say, residency means don't ever ask, your work hours are like 24 hours. You're always on duty. It's not, I don't think it works anymore like that. And so we should know, so this halt, when you are hungry, when you are angry, when you are late, when you are tired, I think these mnemonics we should keep for ourselves. And when am I safe? I'm not safe if I'm ill, if I've taken some medication which can affect my performance, stress, alcohol, fatigue, too much of emotion. I think in your heart of hearts, all of us know that yes, all these things affect us. Solutions in the form of checklists, written protocols. Say, if it is, I'm giving small examples like antimicrobial prophylaxis, if for all departments, if there are written SOPs, so that even the first year resident or the new nurse who comes knows, it would be so much simpler. Similarly, care bundles for central lines, for urinary catheters, how do you have to manage? If all these things are there in all departments, wherever they are used, it would be easier for the human element to work more efficiently. And as I said, all organizations need to have a commitment for patient safety in terms of resource allocation, education and training. Similarly, surveillance also. If I have put a new system in place, is it working? So surveillance is important. Supposing we have used some added new practices for reducing healthcare associated infections, then what was the level of infections before? What was it after? So definitely we need a commitment on the level of the organization and leadership also. And as I said, national level, by ensuring that there is a regulation, there is accreditation, and there is money for research and development. So obviously no single magic bullet, but a change in culture. And to understand that fallibility is part of the human condition, and human condition we cannot really change fundamentally, but we can change the conditions under which people work. So as the Institute of Medicine said, the biggest challenge to moving toward a safer health system is changing the culture from one of blaming individuals to the one in which errors are treated not as personal failures, but as opportunities to improve the system and prevent adverse events. Now, supposing, supposing a drug dose or something, a medication error happens, and the nurse knows that this hospital takes cognizance of this and she goes and reports that this happened without worrying that she will actually be punished for it, I'm telling you, so many things would come out of it. Right? So, fundamental thing is about changing the culture. And I think the components are so many that we need an entire 01 course to go over patient safety. But if I have been able to kind of introduce the topic, I would think that my job is done. And I'm happy to answer questions. Thank you for your